I'm here to give a research update. We participate here at University of Florida. Here, we participate in clinical studies that are investigating different, newer ways of preventing second strokes in people that have had a prior stroke. And I usually like to come and speak to the group once the results of these studies are announced to just keep you educated about that. And recently, a study was published in the New England Journal of Medicine, which is the top-notch journal here in the United States. And did anybody in the room participate in that study? Is there anybody here? No? Okay. All right. So what this study was basically trying to ask was whether or not 2 is better than 1. All right? Now, I think, as you know, aspirin has been around for well over 100 years commercially. The American Indians first used it as it came from the bark of the black willow tree to reduce fever. The medicine men used to use it, so it's been around for even longer than it's been commercially prepared. And aspirin itself is very acidic. It can eat away at the stomach, but it's been kind of commercially. You've heard of Bayer aspirin. Actually, Bayer was a German company in the late 1800s, and they figured out how to make it more, shall we say, palatable to the stomach. So it's been commercially available for 120 years or 130 years. But this study was asking, in somebody who has a minor stroke, let's say a patient comes in with a stroke where a blood vessel is occluded in the brain, but it produces mild symptoms, like a little bit of facial weakness and a little bit of hand weakness or a little bit of a limp, or if they have a TIA. You've all heard the term TIA, right? TIA stands for transient, which means it comes and goes, ischemic, occluded blood vessel attack, sudden. So in TIA, a blood vessel in the brain becomes occluded by a clot. Now that clot could come from the heart, out of the heart, one of the heart chambers, lodge in an artery in the brain, or it could come from a hardened artery in the neck, break apart, go up into the brain. It lodges in that artery, but it then breaks apart, right? You've got all this blood banging up against it coming out from the heart, and it can fracture and go away. So in patients that have had a mild stroke or a TIA, if I give them aspirin, is that as good as if I give them aspirin, and then there's another blood thinner that we use a lot called Plavix or clopidogrel? Have you heard of that? Okay, another drug called Plavix or clopidogrel. Many people who have heart stents put in to prevent clotting on the heart stents, you'll see the cardiologist use both aspirin and Plavix for a year after that. But before this study, we weren't sure if 2 was better than 1. Kind of makes logical sense. 2 should be better than 1 in reducing the risk of another stroke after somebody's had a TIA or a minor stroke, right? We're thinning the blood a little bit more with Plavix plus aspirin than with aspirin alone. So which strategy is better? And in this study, patients were followed out for 3 months after their stroke, because we know the risk of a second stroke is highest after a TI or minor stroke in the first 3 months. All right. So let's just talk a little bit about how aspirin and clopidogrel or Plavix work. In our blood, this is just sort of a cartoon of our blood. Our blood is red because we have red cells. They kind of look like donuts, and those are the cells in our blood that carry oxygen. All right. So those are the red cells. That's what they have, iron in them, and it's the iron in them. The iron latches onto oxygen, and it's the iron in those red cells that makes our blood look red. We also have what you've heard are called white blood cells, and white blood cells are the blood cells that fight infections. But also in the blood are those little white specks. They're called platelets, and platelets are like soldiers out on patrol, and they're looking for areas where blood vessels might be broken. And when blood vessels are broken, they recognize it. And here's an electron microscopic picture. These platelets have little arms that come off, and these arms get very sticky. When a blood vessel is broken, it secretes a protein that it's like Velcro on these arms. All right, and they latch together, and it clots off the broken blood vessel. So if I was to just take a, when we get a paper cut, we cut some capillaries, it bleeds for a little while, and it's not until those platelets recognize it immediately, and it takes a few minutes for them to plug that hole, so the platelets come in. Now, when people have hardening of the arteries, if I go down here, the inner lining of this blood vessel becomes irregular, and because it's broken, it's not broken all the way through, but because it becomes irregular, the blood vessel itself starts secreting some proteins that attract platelets in, and the platelets can develop a little clot on here, and it's that clot, if it breaks apart, that goes up into the brain and can cause TIA or cause stroke. Now, what aspirin and clopidogrel do, it's kind of like they get on these arms here, on the platelets, it's like if I took a piece of saran wrap, on a Velcro strip, if you put some saran wrap in there, it's not going to stick together. So what aspirin and clopidogrel is, they change the chemistry together and they make the Velcro not stick on these arms, so the platelets can't stick. So if you have hardening of the artery here, and this is eroded away, the platelets are going to just float by it. They may try to stick, but they can't stick to each other. All right? Now, they work a little bit differently, but that's basically what they do, is they block the Velcro on those arms there that you see. Okay. So in this study was funded by each of us in the room. All right? It was funded by the National Institute of Health. That is the government branch that funds research devoted to attacking serious health problems in the United States. And every year they get a budget of money. Our tax money goes to them. And each of us threw in, I don't know, a few pennies or a few dollars to help fund this study. So thank you to each of you. But this study was conducted at 279 sites, or 269 sites in the United States, Europe, Australia, and New Zealand, and we were one of those sites. And patients received either aspirin. Now, these are funny doses because in Europe, they don't use American doses. So patients could get anywhere between 50 to 325 milligrams of aspirin once daily, or they could get that same dose of aspirin plus Plavix. And we give a big dose first to build it up in the body, 600 milligrams, and then they take 75 milligrams a day. Plavix just comes in a 75 milligram pill. And all patients were treated for 90 days. Now, whenever we do stroke studies, patients that have had a TIA or a minor stroke, they do have a higher risk of heart attack down the road. So we have to be sure that our drugs, if they reduce all the strokes but they increase the risk of heart attack, it's a washout and it doesn't work. So what we did in this study is we kind of counted the number of strokes and heart attacks that occurred in patients on either arm, and we kept a close eye for any major bleeding, any major hemorrhages in these patients. Here at our site, I think we enrolled somewhere in the mid-40s, 45 patients or so. Internationally, there were 4,881 patients enrolled. So we enrolled about 1% of all the patients in the study here, which is nice. And half of the patients were randomized to aspirin, and half were randomized to aspirin plus clopidogrel. Now this is just up, these are small print, but this is here from my memory. I can't memorize all that without looking at it. So I'm not expecting everybody to get right up to the screen here. But just some statistics for you. The average age of patients in this study was 65. It was nicely split. Half were men and half were women. Whenever we do these studies, we like to be sure that the population in these studies sort of represents the American population. And very nicely, we saw in this study about 1 in 5 patients was African American, which is wonderful. Nearly 85% of patients were from the United States, so the majority of patients were from the United States. The average time that patients had their event to the time that they got the study drug was about 7.5 hours. So this is not somebody who shows up 3 days later in the ER. It was about 7.5 hours. Okay. I think you can just make out these curves, but I'm gonna describe them to you. So these are the classic curves that we show with reference to outcome from the study. So on the bottom, we have number of days. So this is 90 days, right at the end of the graph here. And this is number of patients, or percent number of patients with the event, right here. So here we see patients come in on day 0, and this is the number of patients who either had a heart attack or stroke. You can see pretty amazingly how the highest risk period is in the first week in both arms. If it's going to occur, it's usually going to occur within the first week. And the blue line here represents the percent on aspirin that had an event. The red line represents those on Plavix plus aspirin. So at 90 days, 6.5% of people, about 1 in 16 patients on aspirin, had either had a stroke or a heart attack. On the Plavix plus aspirin arm, 5%, about 1 in 15 or so, 1 in 17 patients had a heart attack or stroke. So there were 1.5 per 100 patients less on the combination than the aspirin alone. So the combination was better than aspirin alone. Now we do some mathematics. I'm not going to go into that. But one way about thinking about this is is the number of patients I need to treat with the combination versus aspirin to prevent one stroke, and that number is 66. So I have to treat 66 patients with the combination as opposed to aspirin alone to prevent one stroke or heart attack. Okay, not a powerful difference, but nevertheless a difference. If we could treat every stroke, and every early minor stroke, and every TIA in the United States with this number, we could probably prevent about, somewhere around 10 to 15,000 strokes, and that number, that becomes more powerful. Now, when we look at the danger, and that's what this bottom graph represents, and we kind of define bleeding. Yes, sometimes people in these studies, they get bleeding, they get a nosebleed, but it stops within 10 minutes. That's not a major hemorrhage. We record it as a hemorrhage, but we kind of define major hemorrhages as those that are life-threatening. So, people on aspirin, sometimes they can get bleeding in the GI tract and lose a lot of blood through the colon. Or people can maybe lightly bang their head, but because they're on aspirin, they can get what we call a subdural hemorrhage, which is bleeding between the skull and brain. It can compress the brain. If it's not drained, they can go into a coma. So we define hemorrhages in these studies as being life-threatening. And in this study, at 90 days, about 1 in 200 patients on aspirin had a life-threatening hemorrhage, but it was twofold higher in the patients on clopidogrel plus aspirin. All right, it was about 1%. So then we think about the number needed to harm. So for every 200 patients that I put on the combination, I'm going to have 1 more major hemorrhage than on aspirin alone. So if we think about the numbers, I have to treat 66 patients with the combination to prevent a second event. But if I treat 200, so I go through that 3 times, 66 times 3 is 200, I'm going to have 1 more major hemorrhage. All right? So if we think about 200 patients, I'm going to probably prevent 2 strokes. I'm going to prevent 3 strokes. If I treat 200 patients, 66 times 3 equals 200. So if I treat 200 patients with aspirin plus clopidogrel, I'm going to prevent 3 strokes, but I'm going to have 1 more major hemorrhage. All right. So 2 patients benefit probably. All right. Now, you understand that? So it's not a big difference, but it's a little difference. All right. So I'm going to prevent 3 strokes for every 200 patients I treat with the combination, but I'm going to induce 1 major hemorrhage for every 200 patients I treat with this. What I can tell you is that the benefit in reducing a stroke was higher in people that came in with a minor stroke rather than a TIA. And we did see a little bit stronger effect in patients who had a minor stroke than those patients who had a TIA. So what the study concluded, and this is taken directly from the journal, is that in patients with minor ischemic stroke or high-risk TIA, those who received a combination of clopidogrel and aspirin had a lower risk of major ischemic events, but a higher risk of major hemorrhage at 90 days than those who received aspirin alone. So how has this changed the way we practice? What we've done is we've actually subsequently, they've looked at when the major hemorrhages occur. And the major hemorrhages tend to be more frequent beyond the first 30 days. So the major hemorrhages tend to occur roughly between day 45 and day 90. They're less frequent under 45 days. So what we've been doing in the hospital, this was published in July, so only a few months ago, since that time, is that in patients who come in with a TIA or a minor stroke, we've been using the combination of aspirin, typically 81 milligrams because it's a lower dose, plus Plavix, 75 milligrams. We usually do it for about 30 to 45 days, 4 weeks to 6 weeks. That way we think we can most magnify its beneficial effects, because you saw that most of the events were very early in the first week, but also minimize the risk of hemorrhage, because most hemorrhages occurred between day 45 and 90. So what we usually do, we usually like to see our patients back after hospitalization somewhere between day 30 and day 45 routinely. So it's at that visit that we usually will peel off one of those drugs. Which one we peel off? Very dependent. You know, aspirin, the nice thing about aspirin, it's easy to get. It doesn't need a prescription. So if somebody, for instance, their insurance doesn't cover any medicines, we may keep them on aspirin. Aspirin sometimes, though, can cause a little tummy upset. I know I've taken aspirin here and there. I get a little acid reflux here and there, so that kind of patient we may keep on the Plavix or clopidogrel. That doesn't cause upset stomach. If patients maybe 10 years ago had stomach ulcers that bled, we may stay away from the aspirin and keep them on the clopidogrel. So we kind of integrate past medical history and integrate affordability. Can they afford the medication? Into the decision making about which of those agents to continue. So this is one step in the direction of us trying to minimize second events after people come into the hospital with a TIA or a minor stroke. Okay. So we thank all of our patients who helped to participate in this study. We generally like to replicate these things in our American population to prove that they're the correct strategy for the patients that we serve. As I mentioned, this study was very nice. The population was 20% African American, which is roughly the percentage of our population that is African American. 2% of the patients in this study were Oriental, and I think 6% were Hispanic Americans, which may a little bit underrepresent that population, but you can see it's a much more diverse population than doing a study in China. But we now have 2 positive studies, and I think the question is answered that 2 is probably better. 2 is better than 1, with the knowledge that there is a slightly increased risk of major hemorrhage when we give 2. All right. So I want to kind of stop there and open the floor to questions. It can be related to this study, or if you want to learn a little bit more about some of the other research we're doing here, I can certainly go into that if you like.
I am confused. Basically, about what one is that yes, the words aspirin and that or aspirin by itself basically.
Mhm. Yeah, I mean, I think the study suggested. I don't. This. I think we have to remember that this is just right in the hospital. This is not a year out. I don't. You know, if somebody right now is on aspirin alone or Plavix alone, I don't want you to panic. That's not what this study showed. All right.
My question for you is, with each stroke, does that up the risk of death the more and more strokes you have?
Yeah, I mean, there is some correlation with that. There is definitely a correlation with that. Mhm. Now, in some cases, strokes are caused by a multitude of effects. We talked here about atherosclerosis. Sometimes people can have clots coming from the heart. Sometimes people can have little microvessels that close off. Sometimes people can have bleeding strokes. In part, it's dependent on the mechanism underlying the stroke, but in general, yes, the more damage that is done, the higher risk of earlier death.
Now, as far as the 90-day period is concerned, and I think I understood you to say that you would give the combination in the beginning, the first 30 to 45 days, to have them come in. But why would it be? I mean, have you guys considered starting the combination at the 45th day or the 30th day, or you just started from the very beginning and stop on the 30th?
Yeah, we usually stop it. Now, we have been, way back when we were involved in another study, looking at patients, all comers with stroke, not just TIA, minor stroke, all comers with stroke, big strokes, little strokes, and they were kept on combination therapy long term. All right, long term. By that I mean, I think it was 2 years on average. Now, in all comers, there was no benefit. 2 was not better than 1, and there was definitely that risk of hemorrhage kept going up. So that study sort of alerted us to the fact that we should not be keeping people on double antiplatelet agents long term. And that's why you see the cardiologist many times that with stents, they take them off after a year and just keep them on 1 year, except in rare occasions. So yeah, even if you go out much longer than that, your risk of bleeding goes way up, and it's probably going to supersede the risk of any benefit of the dual antiplatelets.
Even if you stopped at the 90th day?
Yep.
And last but not least, it appears that the dosage plays a major part in that. And so, is it true that the dosage for a male sometimes should be different than the dosage for a female? Has that been considered yet because of their size and weight?
Yeah, I mean, that's something that's being talked about. You know, right now, unfortunately, I don't know if there's anybody in the room that's been on Coumadin or warfarin. You know, Coumadin is a blood thinner that you measure how well it's working in the blood. Isn't it amazing? Aspirin's been around for 120 years, and we still don't have a blood test that could tell us, yes, your platelets are blocked this much or not that much. So, you know, what you're doing, you know, ultimately, I hope that we can come out with a blood test that tells us this is the right dose to protect you, but it's the right dose to minimize your risk of hemorrhage. It's amazing. It's been around, so it's a difficult thing to do, obviously. So if a company could come up with that, it'd be incredibly successful. But I think that's probably where we're going to be headed. I know it's being worked on. Yeah. Any other questions about that?
I am slow. Yes, do not understand which one is better.
You suggested that the 2 is better than 1, right?
Only in the first 45 days.
In the first 45
Not after 45 days. Yep. There are rare instances. Now, there are some patients, you know, there's always exceptions. There are people in our practice that we keep on both. You know, we may have somebody with a very, very narrow artery in the brain, and we'll keep them on 2 forever. You know, there are some cases that I don't want anybody to panic if they're on 2 right now. But there are some rare cases that we do keep on too. Um, um, just because we think it's the best thing to do. So, but this is the first 45 days. Yep, first 45 days. Yep.
What a doctor wouldn't usually recommend that you take 2 bare aspirin a day, would they?
For just to prevent a heart attack and stroke?
Yes.
With no prior history, I'm assuming, right?
Correct.
Yeah, I would say probably next visit you may want to talk to them about that. Yeah.
I'm only asking because my sister-in-law recently died, and they had put her on the aspirin regimen, 1 aspirin per day, but she figured, oh, it's such a small dose, so she decided to take 2 a day, and she told me this the day before she collapsed with a major brain hemorrhage. And I said, I know the doctor didn't tell you that. And she said, no, but it's such a small dose, so I figured it's okay. She was taking the bare 81, but she was taking 2 a day instead of 1 a day. And she actually hit her head. And listening to you say that, and I'm like, this.
Right.
I felt sick when she said it to me, and the next day she hit her head on a pole. And they said that the brain bleed was so severe, there was nothing they could do, and that's how she ended up passing.
Yeah, I'm sorry to hear that. It may not be that 2 was much different than 1. Sometimes we see people with those brain bleeds not on aspirin. They can occur. Why that occurs is that our brain is floating inside our skull, and there's actually veins, like on the back of our hands, they're thin wall. There's veins that travel from the inside of the skull to the surface of the brain. And when we hit our head, if the torsion is just right, we all hit our head and nothing happens, but in rare cases the brain will twist a little bit and the vein will break and it'll cause bleeding in that area. And we see it in people not even on aspirin. So I'm not sure that, it still may have unfortunately happened if she was taking 1. But yeah, I'm sorry to hear that. Yeah.
Thank you.
Yes. Uh-huh.
Maybe 1 aspirin. Baby dose. They had me on that before they decided that I looked like I had the MRI looked like I had a stroke.
Okay.
Okay. But they took me off of it. I was working in the yard and I just nicked my skin and my sock filled up with blood.
Wow.
It looked like I was profusely bleeding. I didn't even realize it until I looked down and saw the sock full of blood, my shoe full of blood. So this isn't for everyone, in other words.
That's right.
It's individually adopted according to your blood viscosity, I guess.
Yeah, we do occasionally run into patients like you. That even on a baby aspirin, they bruise a lot or bleed a lot. In some cases, we may go every other day in that situation. But you're right. When we talk about clinical studies, it's this is 4,000 patients, and there's always different. Like everything in life, it's a bell-shaped curve. There are people out here that don't quite match profiles here. But no, I understand what you're saying. We see that. I see some people on a baby aspirin a day, and they're all bruised. Their skin's all bruised. And we may go every other day on them or every 3rd day. So sometimes those strategies are used. Just quickly, I know Yasmin Shabir is here. She's our lead stroke coordinator, and she was involved in the study. So thank you for your work.
Yeah, I really enjoyed you talking, and not that I hope I have a stroke, but if I ever have a stroke, I hope that you're the doctor that treats me. You're very, very good.
What is a
Thank
stroke?
you.
I don't know. No, I'm kidding. No, that's great. Well, we have a great team. We have a great team here. A wonderful team here. So, I can't be in the ER 24/7, but I promise you, if you're ever in the ER here with the stroke, you're gonna have very competent people taking care of you here. So, yep.
They were telling me they did an MRI.
All right. Thank you.
It was